This is one of my favorite talks to give, and I've done it a few times, so if you've been with me on these, you might recognize some of it, but I've tried to update it a little bit, add some slides, throw some things that may be pertinent to our season, and we're going to go through women's health and prevention strategies, something that we're all very concerned about, and something that I deal with all day long. So today we're going to talk about cervical cancer, osteoporosis, breast cancer, heart disease, and colorectal cancer. So some of the big topics for women's health care. We're just going to focus on different things, mostly prevention, risk factors, detection, things you can do to kind of prevent and make sure that you're getting your screening and stuff like that. So you and your cervix, everybody get familiar with your anatomy real quick. Everybody remembers from your classes about where everything is. We have these, guys don't, causes extra problems, so we have to look at all this a little bit more closely. Cervical cancer is the 5th leading cause of cancer death in women in the United States. The ranking has gone down. It's not as high as it once was, which is exciting for all of us because of our vaccinations and our detection and prevention. So usually happens after 40 years of age. So it is a cancer of a younger woman. We start being more concerned about cervical cancer and HPV kind of in the 30s. Almost all cases are due to HPV infection. This is one of those cancers, really one of our only cancers that's caused by a virus. We've seen, like I said, a decline because we've had a lot of more people are doing regular Pap exams and getting into their doctors and having these things checked out. So there's usually no symptoms associated with cervical cancer. Just like most cancers, you don't really know you have it until something shows up. Advanced cases, women can come in with bleeding, vaginal bleeding, or other issues, sometimes pain. The treatment is typically surgery. Usually it's a surgical fix. You get a hysterectomy, take out the cervix, and find out any other parts that it could have spread to. You might have to have chemotherapy or radiation associated with that. So HPV is kind of a big topic. We talk about it all the time. It's constantly in social media right now with people with young kids and trying to get vaccinations. So there's a lot of controversy kind of around this. So this is our time to kind of learn about it and get our kids taken care of and understanding what's going on and how this is transmitted. So sexually transmitted. Most common sexually transmitted infection. That's how HPV is transmitted. It's the only way you can get it. There are 40 types. We know all the different types, but only certain types of them actually cause cancer. The other types cause more like genital warts and just kind of disfigurement of the vaginal area and that kind of thing. Most of them, 90%, are asymptomatic and go away in a couple years. So you can get HPV when you're in your 30s. Most of the time, 9 out of 10 women, it's going to completely go away on their own. It's not going to cause any residual damage, and you're going to be fine. But it's that 10% that does. That 1 in 10 woman that is going to have to come back, have things looked at again, may have to have some kind of treatment to kind of prevent her risk for getting this cancer. Persistent HPV, persistent, just keeps coming back, that's why we screen, is what is going to cause cervical cancer and warts. So, low-risk infections, like I said, cause the warts. The high-risk cause cervical and other cancers. And again, I wanted to reiterate, nearly all the cases of cervical cancer are caused by HPV. Risk factors for HPV include multiple sex partners. Obviously, if it's sexually transmitted, multiple sex partners, sex at an early age. People always wonder why that is the case. It's not necessarily because if you have sex at an early age, chances are you're going to keep having sex with multiple partners. That's part of it. But the other part is the cervix is so immature at a younger age that the important cellular part that's being exposed to the virus is more damaging at that point in their life. Once a woman gets older, that cervix and the inside part of it goes up into the body, but when you're younger, it's out. And so it gets exposed to that virus through sexual transmission earlier, and it causes more damage earlier. If people have other sexually transmitted infections, obviously they have a bigger chance of getting this one. Smoking is a risk factor for any cancer. Every every cancer we're going to talk about today, smoking is a risk factor for it. Condoms are only partially protective against this particular virus, so there's still a lot of other, condoms are, we really preach it, we want people to be using them to protect them, but they're only partially protective. Nothing is 100% unless you're just not having sex. So the HPV vaccination, which is what is controversial right now, is very effective and highly recommended by your medical community. All of us are going to recommend that this vaccine be given. There are 3 different types on the market. We're all kind of going down to the bottom one where we're giving the 9-valent because it covers 9 different strains, high-risk strains. And we're giving it to boys and girls as young as 11 years old. So as you remember what I was saying about the earlier cervix and the younger cervix being exposed, if you get the vaccine earlier, it protects you more. They even think it might even kind of incorporate into your growth and your DNA, and it might help even protect your children if you're getting this vaccine earlier. So it's kind of neat. Lots and lots and lots of social media angst and negativity and stuff towards this particular virus. It's going to cause all these problems, and there's these marches and moms against Gardasil and all that. You'll see it, and there's a lot. I mean, there's a lot of concern. Anytime you give your child a vaccine or take a vaccine, you take a risk for things to go wrong, but it is very safe and highly recommended, FDA approved, and we are encouraging everyone in this age group to go ahead and get it. It's not required for school entry. It probably won't ever be because it is so controversial, but most of my patients, it just takes 2 minutes for me to kind of explain to them what it's about, how effective it is, what kind of things we can prevent, and most people are on board right away. So it's just an education thing. If we can spread the word and educate, I think we can keep a lot of our youth from having problems. Now, young men can get testicular cancers, penile cancers, and all kinds of other things from this as well. So not as common as cervical cancer, but it can cause problems in the middle as well. So the PAP exam is recommended for all women ages 21 to 65. Under 21 years of age, a pap smear is not needed. And the reason behind that is because it takes a long time for even HPV to kind of start doing what it's going to do. Even if you had early intercourse at 13, it's still going to take several years before any changes are going to be seen. You're not going to do a whole lot for a young woman who has the virus except for watching. So doing the PAP exams are not really necessary under 21. And that's changed. A lot of people come in to see me, they bring their 16-year-old in, she needs a pap smear. We aren't really doing a lot of that. So it's more like 21. 21 to 29, you can get your pap smear every 3 years. And this has changed a little bit too. It used to be every year, now it's only every 3. And then once you're 30 to 65, your pap can be every 3 to 5 years, as long as your doctor is screening you for HPV. If they don't do the co-test where they actually check you for HPV, then you still need to do it more frequently. So make sure if you're in that age group that your provider is doing the HPV screen. So, after 65, PAPs are not necessary. I think that's individualized, and I think it kind of needs to be a discussion with you and your provider of whether you need one or not. We are sexually active longer in our life now, where people are remaining sexually active, or they may have other partners even after 65, so you're still at risk for HPV. And so I think that's an individual decision. So a lot of my patients still choose to have pap smears after 65.
How long have they been doing that HPV test?
The PAP, that's probably been, well, it's been available for about 10 years, like the straight co-test. I don't know how many, people or how long they've been doing, because there are options when you do your PAPs. We have like 6 or 7 options to check on the form, and you have to kind of make sure you're checking the right one, because they can just do a standard PAP, but you want to make sure you're getting what's called a co-test. That's what it's called. But that's been available for about 10 years. So if you've had a PAP, most likely you've had that co-test if you're in that age group. So If you no longer have your cervix because it was surgically removed for non-cancerous reasons, you just had bleeding or other problems, you don't have to have a Pap test. Now, if you had had cancer, you still have to have those done because there could be residual cells, there could be other things that need to be screened as well. So you do still need to have that. And of course, your doctor, your provider, they're going to be the ones that's going to know what's tailored to you because your scenario may not fit into this category here. You may need to look outside the box a little bit for your own self. So prevention obviously is education, like I was saying. When we talk about HPV, we talk about how it's transmitted. It's sexually transmitted, so obviously abstinence, decreasing number of sexual partners, trying to get young girls to wait before they start having intercourse. Condom usage, we do encourage that. If it's unavoidable, we'd rather do something than nothing, even though, as I mentioned before, it's only partially protected or preventative. So vaccines as early as age 11, smoking cessation, Pap smears, physical exams, and then treatment of those persistent HPV Pap smears. So when those start happening, especially in that decade between 30 and 40, if that Pap smear is staying abnormal, things need to be done. We need to be biopsying, freezing, doing other procedures to try to make it go away.
Do you know what our Texas rate of HPV vaccination is these days? I don't either, I just was curious where we were with that.
Where we are on that? Yeah, that's a good question. I should have probably looked at that, but that's a good. The CDC would probably have that on their website, kind of what's, and the ACIP who puts out those guidelines. But we've all been very focused on trying to get this, and I've made it into my standard 11-year-old panel. You come in and you're 11, you get your tetanus, you get your meningitis shot, and then how about this HPV shot? It's so wonderful. And we talk about with the kids, we say this is a shot that you're going to get, but it means nothing to you right now, so don't worry about it. But 10 years later, ask me about it, and then it'll make more sense. And so try to encourage parents too. It has nothing to do with their bodies right now. It's for later. And for the boys, you're going to have a daughter-in-law someday that this is going to affect. So let's go ahead and do this. And that works. People appreciate that and putting it in that light, and it makes sense. But
is that covered by most insurance?
It is. And there are patient assistance programs for people without insurance, and I virtually get 0 people that aren't qualified. So I mean, everybody can get it. So, and it's available through Vaccine for Children, or the Texas as well.
I didn't know since it was so controversial if it was.
No, I mean, no, and the controversy is just, you know, social media. We have to blame social media. It just goes like wildfire, and it's just kind of scary, the information that you read and you think this is so false, this is so not true, and so we have to be careful. But when it first came out, I don't know if y'all remember when it first came out, especially in Texas, they tried to make it mandatory for schools, and everybody just went crazy. And so that was so detrimental to the vaccine itself, because we needed to do it, but it didn't need to be required. They don't need it for school, but so the politics at the time kind of contributed to that. But they backed down off that, and I think we're on the rise, because I am literally, you know, I've been here, this is my 13th year here, and I take care of a lot of the women, a lot of the younger people, doing a lot of these PAPs and procedures. I'm doing less and less. I'm almost excited to get to do a colposcopy or a biopsy, because I just don't do as many anymore, and I attribute it to early detection and vaccinations. So. All right. So the well woman exam, even if you don't need a PAP, like we were discussing, you've had yours, you're doing it, you still need a well woman exam. You still need to talk about birth control if you're still in that age range, hormone replacement if it's necessary, STD risks. You need breast exams, you need mammograms every year after 40. If there's urine issues, bowel issues, colonoscopy, osteoporosis screening, the screening for other things like heart disease, because heart disease is the #1 killer in women. So that's very important to incorporate into your well woman. A lot of my really healthy women don't come to the doctor except for their Pap smear. So I get them in there, and we're going to check cholesterol, we're going to check all these other things, because that's my one chance to kind of get them screened for any concerns down the road. So osteoporosis is another thing that women are very concerned about. it's a chronic and progressive disease that is characterized by low bone mass. The bone deteriorates, gets fragile, and it increases your risk for fracture. 50% of all women will suffer an osteoporotic fracture. So, you know, every other person in this room is going to have a broken bone because they have osteoporosis. So, and it's not really the fracture that's the problem. It's everything that's associated with the fracture. So you break your hip, you end up in the hospital, you don't move, so you get a blood clot. Or you break your hip, you can't move, so you get pneumonia. Or you catch something while you're in the emergency room. It's just all that stuff that goes along. It's not the fracture that's going to kill you. It's going to be all the sicknesses and stuff that you're going to get in part. The immobilization. People have to be put into nursing homes and stuff like that. So we don't want to get those. Risk factors, just like anything, excessive alcohol intake, excessive caffeine intake, and tobacco use. So the moderation, what's considered in moderation for alcohol is 1 to 2 drinks per day and less than 2.5 cups of coffee. I think I blew that one out of the water this morning. Yeah, I'm sure I did. I'm feeling it. So, I need to work on that one. If there's a family history of osteoporosis, that puts you at higher risk. People who have hormone deficiencies, obviously, and low body weight. This is the one thing that astounds a lot of my patients. I know, the one thing, we want you to be thin, we want you to have low body weight, but guess what? You're at higher risk for osteoporosis. So I always tell them, they're like, are you kidding me? And so women that are obese don't get osteoporosis because they're carrying around extra weight. But that's the only thing they don't get. So if you're a smaller person, you're at higher risk. You're not carrying around extra weight. If you're on steroids, if you're a smoker, and then whites and Asians tend to have more osteoporosis. Screening recommendations. This is going to vary depending on who your provider is and depending on which guidelines your provider is going by, because there's probably about 6 of them. Every woman over 65 years needs to have a bone density screening. Will Medicare pay for it? Probably not. Just going to throw that out there. So your doctor is going to have to get creative and figure out a way to get Medicare to pay for it, but there are ways. So any postmenopausal woman that's in their 45 to 50 year range that is thinner, maybe on medications or have other medical disease will qualify for it. So those are the ways we get these approved. I pretty much start everybody at 50. Every other year they get a screening. If I start them at 50 before they hit Medicare, then once they get to Medicare, I can track it and show them that this is what we're doing, and then Medicare like, oh, okay. But if I wait until they're 65, Medicare won't pay for it. So just daily. So no more than 1 or 2 year intervals. A lot of people think they need to have it every year, and you don't. You only need it every other year. And based on those results, your physician may choose to screen you more frequently. If you're on long-term steroids or other risk factors, there may be an indication for that. Bone density tests are easy. I don't know, anybody had one? I mean, yeah, so you all have, you know how it's just quick and easy, and you're like, that's it? They can do a wrist, x-ray, a hip, or a low back. They calculate a score, and they're able to determine your risk for osteopenia or osteoporosis. Very little radiation in this.
What's the difference
Between osteopenia? So my next slide shows, so osteopenia is kind of like the precursor, like the step before you're going to get full-blown osteoporosis. So on these tests, you get this T-score, and if you have a certain score, you're considered normal. If the score is between -1 and -2.5, then it's osteopenia. And they do that test based on your bone and your age. So they have this whole diagram that they can figure that out. And then, of course, if you're higher than the -2.1, then you're considered osteoporotic at risk for fracture. And your provider can tell you what your percentage is based on this. Like when you get your test done, ask them, what's my percentage? What's my risk? 5%, 6%, 12%. It'll give you a percentage of how brittle your bones are on this test. So.
Years ago, when they first started having health fairs out here, they did
Wrist.
oh my gosh, Karita, you're in a wheelchair at this stage. And
Yeah.
it just scared me to
Right.
death.
Well, and we've stopped doing the wrists ones as much because they were kind of like, well, this isn't really a very stable area anyway. So we're taking more, we're getting more information based on the hip and the lumbar spine now.
So
So
I've had a full,
the full blown.
Yeah.
Yeah, the early DEXA scans were just the wrist, and they kind of decided after a while, well, this is not really giving us that much information. We need those weight-bearing bones to kind of tell us what's going on. But a
is
lot of
walking good for it.
walking is very good for cardiovascular health. It is good. It's better than nothing for osteoporosis. Weight bearing is the best thing for osteoporosis. So if you're going to choose walking as one of your exercises to prevent osteoporotic fractures, you need to use weights. So dumbbells, ankle weights, thigh weights, something to add weight to you so that your bones are getting extra weight. So when I see women out walking with their dumbbells, I'm like, they're preventing osteoporosis by doing that. So weight-bearing exercise. Circuit training is very good because circuit training incorporates a lot of weights, and you want that weight bearing on your bones and resistance training, and that really helps strengthen bones. When we used to have curves here in town, was it curves? Is that what it's called? They did the best kind of osteoporosis kind of prevention stuff because you just did all those little circuits, and I'm kind of sad that we don't have anything like that, but yes, weight bearing is the best thing. So what can you do to prevent it? Well, don't fall. You know, I try to wrap my patients in bubble wrap, but it doesn't always work. Quit smoking, modify your coffee and alcohol intake, and make sure you're eating a diet that's got a lot of vegetables. You need vitamin D, calcium, protein, fruits. And then what I was talking about, the multi-component exercise with strength, balance, weights. And sunlight exposure, we all know that you get your vitamin D from the sun. It's not always convenient for us to be in the sun at least 30 minutes a day, so you can do vitamin D supplementation. Calcium supplements these days, when you go to buy them, they're usually in combination with the D. So when you see that product with the D on the end, that's your vitamin D that you need. Sometimes you can also get some prescription strength from your doctor as well. So I handed out this because I just love this little chart. This is the little calcium. So I think that everybody's a little confused on how much calcium you need. And there's, basically 900,000 products out there, and which one is good and which one should I use. Women need 1,200 milligrams a day, pretty much across the board. And they always come in a 600 milligram tablet. You have to take them separate from each other. You can't take all your 1,200 at the same time. I always want to make sure that everybody understands that. You have to take 600 in the morning and 600 in the evening. It drives everybody crazy because who wants to take it twice? But you won't absorb the full 1,200 if you take them together. Unless you buy the slow release, because they have new products that are slow release. So just look at what you're taking. If it's a slow release, you can take it. Citracal is the one that I take because I can't remember to take. I don't have time to take pills all day long. So I want to take two. So I take the Citracal D, it's 1,200 in the morning, and it works all day long. You slowly release it and absorb it. So there are more products like that. This is only absorbed at 500 to 600 milligrams at a time. The rest of it, you just poop it out, and it doesn't work. So, and as you know, calcium can be constipating, so you have to be careful. So look around, shop around. The Citracal products tend to be less constipating. So for those of you that are constipated, most women are. So try that one. Calcium can interfere with prescription medication, so talk to your provider about that. Number one on the list is thyroid. So if you take thyroid, do not take them together. You need to separate them by 4 hours. So. Any questions on that? I really like to drive that one home. Okay, so breast cancer, obviously, we're all talking about that this month, our big breast cancer awareness. Other than skin cancer, it's the most common cancer for women. Believe it or not, skin cancer is actually the most common. Leading cause of cancer death in women. The average age is 61. Different types. We have the invasive ductal carcinomas that affect the actual milk ducts of the breast. And then you have the invasive lobular, which affects the lobules or the fattier parts of the breast. Symptoms usually are lumps. You'll get a lump in the breast or the armpit. The breast might swell or be a little thickened. It can be irritated. You can see things kind of dimple. Some women can get redness or flakiness to the area, like a red spot. And then some people won't have any of that, and they'll just have discharge coming from a nipple. And once you've kind of hit menopause, you're not having children, you're not breastfeeding, you shouldn't have anything coming out. So if there's anything coming out of your nipple ever, you should be seen for that. You want to make sure that it's, number one, not a cancer, and number two, not a hormone problem, because some hormone problems from your pituitary or brain can cause breast milk production, and that's not really normal. So sometimes pain to the breast. I usually tell my patients cancer is not painful, and that's typically true, but you have these glands of your body sticking out, and suddenly you have a mass and it's rubbing on things, or it does get irritated. It does cause pain, and it can cause a deformity and some discomfort. So breasts can be a little bit painful if there's a lump. The risk factors for this, of course, as you get older, you're at higher risk. If you have a genetic mutation, you guys have probably all heard about the BRCA genes. Those are things that you can detect. Doesn't necessarily mean you're going to get it. It just means that you have that mutation. Women who started their period early are at higher risk for breast cancer because they've had more hormone exposure. Late or no pregnancies, because when you're pregnant, you get a break from all this stuff. And women who've had lots of babies are at less risk for breast cancer. Late menopause, so early menstruation, late menopause, a prolonged period of all the hormones kind of going or being active. If you're not physically active or overweight, women that have dense breasts are at higher risk. People who've used combination hormone therapy or birth control pills are a little bit slight risk for breast cancer. Family history. If you've had radiation for other reasons, maybe you've had lymphoma or you've had melanoma or maybe a thyroid, which is pretty common, it can have, the radiation could have exposed your breast, and you may be at risk for that. And drinking alcohol is in there too. So we want people to maintain a healthy weight, exercise, limit alcohol. You can kind of see the main, the common denominators here. No smoking, limit alcohol, exercise, avoid carcinogens, limit exposure to radiation, and then talk to your provider when you're on a hormone or a birth control. Make sure that you still, that everybody's still aware that you're taking these, sometimes it's just like refill, but maybe something's changed in your history, or you found out that your sister had breast cancer. Your doctor might want to talk to you more about, now that you have a personal family history, we might want to rethink some of these therapies for you. So make sure that you're talking to your providers about that. And then, of course, breastfeeding is protective for the breasts as well. Most guidelines recommend yearly screens for breast cancer screening. Several different, again, there's so many different guidelines, and sometimes it's hard to wade through it and figure it out. Most of us start at 40. Some of the guidelines say 50, but I'm usually shocked if people haven't had a mammogram by the time they're 50. So 40, you should get them every year. If you have a personal or a family history, like a close family, we're talking sister, mother kind of relationship, you need to go 10 years earlier from when they were diagnosed. So someone was 47, my sister was 47, then that woman should start at 37 and start having those. Mammograms are a little bit hard to do when you're younger because your breasts are very dense, and so the provider may choose to do like an ultrasound instead of an actual mammogram. But the breasts should be screened earlier if there's that risk. So, oh yeah, yeah. We should definitely mammogram instead of Instagram. I mean, if you want to Instagram while you're getting your mammogram, go right ahead. Just don't put the OGH logo on the back.
Yeah. Let's not do that.
Oh, so yeah, so mammograms, everybody is aware of what those are. They're really not as bad as they seem. Everybody in here had a mammogram, or at least close, y'all probably have.
Yes, they are when
Yeah.
they're pretty much flat chested.
Yeah, yeah.
They're painful.
Yeah, yeah. The digital ones, because we're using more digital technology now, they don't have to squeeze as much as they used to, so that is a benefit. But yeah, when you are smaller breasted, they are a little bit more painful. So, clinical breast exams are done in your office when you do your Well Woman exam. Self breast exams are done at home. We usually tell people go ahead and do those in the shower when your hands up above your head. You're just feeling your breasts and up into your armpit. Remember, you have breast tissue up into the armpit. The best time if you're still menstruating is to do you don't want to do it right before your period or on your period because your breasts are real lumpy and painful. So wait till 2 weeks after your period, and that's the best time to check your breasts. Should be doing it every month. You're going to know your breasts the best. We do them every year. We do your mammogram every year, but you know what your body is. You should check it. Okay. So if abnormal, a lot of times you might have to have a diagnostic mammogram, which is maybe a little bit more invasive. They may want to do a breast ultrasound or MRI and biopsies. And we are doing digital mammography at OGH. We have an on-site radiologist that will do an ultrasound, biopsy, draining cysts, all of that right here on site. We're very, very happy to have that. And it's very wonderful to be able to do that right away and get some. There's a lot of anxiety that goes along with having an abnormal mammogram, and if we can do it all together, it's way better for the patients. Okay, so here's your slide. It's really not like that, but you might feel like that. Just wear a long, flowy blouse. How's that? All right. So again, I was talking about the comprehensive digital mammography. We have a Texas Tech grant to help fund mammograms for private pay patients, which is really nice. If you know somebody who says, I just can't afford a mammogram, tell them to come talk to us because we can help them. There's discounts during this month. Mammograms are $100, and that's like a super steal. And then we're also doing bone mineral density tests as well. So those can all be scheduled. You don't even have to have an order for that. You can just schedule them yourself. You do have to kind of assign a doctor to look at it, but you don't even have to have your doctor order it for you. So like I said before, the breast cancer approach is just individualized. We all wear different size bras. Of course, our treatment and prevention are going to be different based on that. So just know that it may be different for everyone, but we need to be doing it. Any questions on breast cancer prevention? Or don't look up, there's a loss. So heart disease is the leading cause of death in women. We all think breast cancer gets all this publicity, and that's the leading, it's not the leading cause of death. Heart disease is. By the highest cause of death in women and men is heart disease. 20% of deaths are related to, 22% are related to heart disease. Women are at risk just as much as men. It used to be, oh, women aren't at risk, men are the ones, but it's not the case. We are just as much at risk. But and it's harder because our symptoms aren't as classic. It's not that crushing elephant sitting on my chest. Women won't have that as much. I mean, we can, but it's not always going to be the same. It could just be like my jaw hurts or my arm hurts or something like that. It could be as subtle as that. So 2/3 of patients that are suddenly having heart disease may not have had previous symptoms. Angina is what I was just describing, that dull, heavy pain. It could be a pain in the neck, jaw, throat, upper abdomen. A lot of women will have it in their back. Typically, you'll have nausea, sweating, kind of when you're having a heart attack. shortness of breath. You could have these symptoms while you're at rest. It could be while you're doing activities. Stress can cause it. And it could be associated with, having a heart attack can be associated with heart failure, other rhythm disturbances, or strokes. So there's a lot of stuff that ties in. So I just wanted to throw this one in there, and when we're talking about the leading causes of death. So heart disease is number one, and then cancers in that order: breast, lung, colorectal, uterine, thyroid, cervical. Cervical is number 6 as far as incidence, but it's number 5 as far as deaths. Usually don't die from thyroid cancer, but it is common. Lower respiratory diseases, like pneumonias and stuff, stroke, Alzheimer's. And it's not the Alzheimer's that's going to kill you, it's everything that goes along with it. The immobilities, the pneumonias, the blood clots, and everything that goes along with having severe Alzheimer's. Unintentional injuries, obviously like car accidents, things like that. Diabetes, and then influenza and pneumonia is still on the top 10 of death for women. It's like, we have a vaccine to prevent this. We should probably get that. Kidney disease, and then septicemia, which is blood poisoning. So I thought that was really interesting to see. This was 2018 statistics. So risk factors for heart disease, this is the big thing. This is what your doctor is going to spend a lot of time with you is, if you're diabetic, high risk for heart disease. If you're overweight, if you have a bad diet and you're not active, you drink a lot of alcohol, again, same things. High cholesterol, high blood pressure, family history, smoking, and high stress. So out of everything on this list, there's only one thing you can't help. And that's your family history. Everything else we can help. And so we can treat your diabetes, we can lose weight, we can quit smoking, we can get our cholesterol under control and blood pressure under control. We can't change who we are genetically, but that would just leave you with one factor. So all of these things are very modifiable. So the ABCs of heart health, this comes from the CDC. Appropriate aspirin use, blood pressure control, cholesterol management, and smoking cessation. They kind of have compiled it to this simple algorithm. If you can do these things, then you lower your risk for heart disease dramatically. Aspirin is not necessary for everybody. You're probably thinking, well, then why are you taking aspirin? Most people don't need to take aspirin unless they have had heart issues or if they've ever smoked. You don't have to be an active smoker, but if you've ever smoked, you should take aspirin. And we use the low dose, the 81 milligrams for that. All right, so that's heart disease. Any questions about that? That's probably a 5-hour lecture down the road. So. Just a lot of things right there. So we'll move on to colorectal cancer. The last time I gave this talk, I didn't put anything about colorectal cancer, and I was kicking myself because it is a very common cancer in women. Third leading cause of death. And not really even the death, it's just, even if you survive it, there's a lot of complications that can go along with colorectal cancer. But it's a very preventable cancer, that's the other thing. And 1 in 24 women will actually get colon cancer, so very common. It can be detected early and it can be treated, so it's one of those that you want to figure out, you want to get it taken care of, and you want to be done. You don't want to just be caught unaware on this one. Colon cancer can affect, you see how much colon, intestine, everything's just in there. You have so much and it has to be monitored. It's not given the credit it deserves because it's all in this little area, but it's a huge organ and it has to be looked at. Again, your risk factors, smoking is there. I love that cartoon because I thought, that is what I should do. I should give people patches and just put it right there. That will work so much better. Yeah. So other than the things we've always mentioned with the other things, a diet high in red meat and processed meats, I thought that was interesting. Puts you at higher risk for colon cancer. So like processed meats are going to be like your lunch meats and stuff that have a lot of nitrates in them. Hot dogs, sausages, things that are processed. You can have those things, but you shouldn't be eating them 3 times a day. Really, anything that has that many preservatives, you should eat them 3 times a day. but a little bit is okay, moderation. People who have polyps, if you've ever had a colon polyp, you're at risk for those developing. If you've had inflammatory bowel disease, which is like Crohn's disease or ulcerative colitis, then you're at higher risk because there's a lot of inflammation going on. Of course, family history is a big one. There's a lot of genetic disorders that cause it's early colon cancer. People typically get it in their 40s. Lynch syndrome, familial adenopolyposis, those are all ones that you're probably going to know if somebody in your family's had this, and you're probably going to have the genetic screening for it. There's a lot of those. And then ethnicity, the Ashkenazi Jew population, they actually have a huge incidence of colon cancer, like out of all of the populations in Europe. And through 23andMe, I figured out that I have some Ashkenazi Jew in my system. And so I'm like, wait a minute. So I'm like, okay, I'll get my colon screening, don't you worry. So, type 2 diabetes also is a risk factor for that. So, again, screening protocols. Some people say start at 45. Most of us typically say start at 50. Colonoscopy, we'll get to that here in a second. 45 to 50, up to about 75 to 85, depends on your health and prognosis. So again, we're living much longer. Being 75 is not what it used to be, so you may need another colonoscopy after you're 75. So it's individualized and should be a discussion. Higher risk individuals, of course, if you know you have a genetic syndrome, you should have it earlier. I have people in their 20s getting colonoscopies because they have they have that family history. And they find polyps at 20. They'll find them, biopsy them, they're okay, but we got to keep track of it. So after 85, we probably don't need to be doing it anymore. The types of screening, there's a stool-based test. Y'all might have had those done in the office when you maybe had your well woman exam. It's just a rectal test. Those can be done every year. They're not as good as having a colonoscopy, but it's better than nothing. They have the new test, and I put this in here because you might have seen this on the news or on Facebook. Cologuard is a new test, and a lot of us are offering it to our patients, and they contact you, and you have to poop in a bucket and scrape it off and send it in, and then they tell you if you have any of the DNA stuff that goes along with colon cancer. And while it's still not a colonoscopy, it's still way better than doing nothing. And I think I can talk most of my people into doing that. The pooping in a bucket part is a little bit hard, but most people will do that. So that is an option, and it's widely available. Insurance will pay for it, and it's approved. So, but the best way, if you want the best test for this, it's a colonoscopy. And now, if they're normal, those are every 10 years. You only need to get them every 10 years. Direct visualization of the problem is the best way to go when it comes to your colon. We have Dr. DeWitt, our new provider here in town, is offering colonoscopies. We had our first colonoscopy at the hospital today, so we're really excited about all the updated equipment. So he's going to be offering those. So that's an option for people who didn't want to travel out of town. They're not as bad as they sound. The prep is worse than anything because you have to kind of clean out the colon. But all of us could probably stand a colon cleanse from time to time. So just go get it done. You'll go to sleep, you'll wake up, and you'll be like, that was it, and then you're good. So definitely something you should be doing, and your spouse's partner should be doing it as well. So, and that was my last thing on women's health prevention, but I wanted to throw this in here about vaccines. As you can tell, I like vaccines. Flu shots, please make sure you're getting them because as you saw, number 7 on the list of killers for women is flu and pneumonia. Kids 6 to 59 months old should be vaccinated. They're high risk. Anyone over 50, anyone with a chronic medical condition, and that could be a thyroid disorder. That puts you at risk. So you don't have to have full-blown heart attack to be in that category. Pregnant women across the board, they walk in my office, they're going to get a flu shot unless they can arm wrestle out of it. So high dose flu, if you're over 65, it's a little bit stronger version, and we do recommend that. And then the pneumonia vaccines, we have the 23 and the 13. Those should be, you can start getting those when you're 50, and they're every 5 years. After 65, you only need one of the two, and you're done after that. So, I think that's all I have.
When do you need your second pneumococcal
So,
pneumonia?
like for the two different types, you have to separate them by a year. So the traditional pneumonia shot we've had forever is the 23. So if you've gotten a pneumonia shot before, it was probably the 23. So the way I've approached it is if you come to me, I'm going to give you 13 because I know you've had the 23 before, and then the next year you're going to get the 23 again. Yeah. But after you're 65, you only need to do that each one of them once, and you're good for life. If you're before 65, you do need to repeat them every 5 years each.
So if you've gotten one 30 years ago, you probably need one.
Probably. Probably so. You need both of them. You'll need both of them. But you can't get them together. It's kind of weird. The other thing I didn't put on there too, and most of you probably know this, is getting updated on your pertussis vaccines, the whooping cough. All the babies are getting whooping cough because the adults are giving it to the babies with our unvaccination rates going up. Whooping cough has kind of made its way back. So if you're ever going to be around a baby, which, you know, all of us want to be around babies, you need to have that booster. And you only need it one time. One booster is all you need. Well, and I tell my patients, you just have to tell grandma and grandpa, like, you want to snuggle with this baby, you better get this vaccine. It's interesting, some of the drama we get because of it. What are you saying? So any questions about any of these topics? Well, I really appreciate y'all being here. I always enjoy sharing some pearls with you. And then I think, Lindsay.
We have a draw